this video, we will be discussing agents used for the treatment of anxiety disorders, where anxiety is an emotional state caused by the perception of a real or perceived danger or stressor that threatens an individual. And this is an adaptive response we all experience when faced with a threat or stressful situation. But in those with anxiety disorders, this response includes psychological and physical symptoms that interfere with daily life in the absence of an appropriate threat or stressor to trigger this response. In addition to fear and anxiety, this includes sympathetic-driven responses or that fight or flight response, where we are going to have palpitations, shortness of breath, perspiration, and muscle tension. And it is thought that this is due to conditioning or a learned response to a non-threatening stimulus. And this conditioning is going to lead to imbalances in neurotransmitter signaling. But the exact pathophys is not well understood, like many of the other psychiatric conditions we have discussed. So the neurotransmitters thought to contribute to anxiety disorders, and those that we primarily target with anxiolytics or agents indicated for the treatment of anxiety, include GABA, which based on the schematic will be our primary focus in this video, and then also serotonin and norepinephrine, which we covered extensively in other videos. So let's begin with a brief review of serotonin, which remember is our great stabilizing neurotransmitter. So this is going to regulate a number of other transmitter systems as well. And in anxiety disorders, serotonin signaling is imbalanced potentially due to reuptake transporter and receptor changes. For example, there can be increased expression of serotonin 2 receptor subtypes on the postsynaptic side, which remember from the antidepressant video, promote anxiety. Next up is norepinephrine, which makes sense if you think about that fight or flight response and that autonomic arousal which accompanies anxiety. And norepinephrine can promote fear responses centrally, so it is generally thought there is elevated norepinephrine signaling, potentially through changes in receptor expression and sensitivity changes. So because of the involvement of imbalance and generally considered adrenergic and serotonergic signaling, many of the antidepressants, like our SSRIs and our SNRIs, are our first line options for maintenance treatment for anxiety disorders. Now, thinking back to their mechanisms of action, this may actually worsen anxiety short term because of the elevated neurotransmitter levels in the synapse at first. But over time, with that receptor regulation, these signaling pathways will be modulated to more appropriate levels. So again, starting low and titrating slow to minimize this worsening of anxiety initially. Now, I just wanted to review these antidepressants in this new context of anxiety, but now let's move on to the neurotransmitter that we will focus on moving forward. Now, GABA we know is our primary inhibitory neurotransmitter that is released from nearby interneurons to modulate the release of many other neurotransmitters, like our norepinephrine and our serotonin, whose signaling is imbalanced in anxiety disorders. So GABA will be released to then act upon our GABA receptors, like our GABA A receptors, which remember are ionotropic or linked to ion channels that facilitate the influx of negatively charged chloride ions to the presynaptic and postsynaptic nerve terminals, and we're going to counteract that positive charge influx that's trying to trigger that neurotransmitter release or that signal propagation. So if sufficient enough, this can actually inhibit this signal cascade, promoting that inappropriate psychological and physical arousal so that the normal adaptive response to fear and anxiety remains appropriate. Now, unfortunately, those with anxiety disorders have been shown to have imbalances in their GABA signaling as well, potentially due to low GABA levels or receptor changes. Without this regulation, neurotransmitter release like norepinephrine and serotonin go uninhibited, leading to inappropriate anxiety and sympathetic arousal. So now, if we are able to supplement this low GABA signaling with pharmacologic agents, we can also restore some balance to the GABA system and the downstream other neurotransmitters, along with our SSRIs and SNRIs that are balancing that serotonin and norepinephrine systems. So moving to our next slide. In our last group of agents that we will discuss that are used for the treatment of anxiety disorders that we mentioned in the anti-epileptic video are the benzodiazepines. Or you might see these abbreviated as the BZDs. So the way these agents work for anxiety is very similar to the mechanism of action we discussed in the epilepsy video, where these agents will bind to an allosteric site on the GABA receptors, which is known as the benzodiazepine receptor. And on these receptors, on the synaptic nerve terminals, these are going to act as a positive allosteric modulator when GABA is bound to the receptor. So benzodiazepine binding with GABA leads to increased channel opening and prolonged opening, increasing chloride ion influx, inhibiting neurotransmitter release and neuronal firing. Now, these agents are effective in treating anxiety, but there are a number of key considerations that must be kept in mind. One of the most important is that unlike the SSRIs and the SNRIs, these are controlled substances. That are going to come with a real risk of psychological and physical dependence and misuse. Now, because of the risk, these agents are mostly used initially in the short term while the SSRI or SNRI reaches full effects. And long term, you should be reserved for those unable to tolerate or benefit from these first line, more long-term therapy options. And long-term therapy with a benzodiazepine should be approached with caution because there are other considerations besides this misuse potential. And if for whatever reason they are used long-term and need to be discontinued for any reason, they must be tapered slowly to avoid withdrawal. Now, the next considerations have to do with pharmacokinetics and how benzodiazepines can be grouped based upon half-life. So short, intermediate, and long acting benzos. And now you can find a few different cutoffs and lists. So this will vary between sources, but it's important to just appreciate that there are key differences. But usually anything less than 6 hours is short acting, and this is going to include agents like alprazolam, triazolam, midazolam, and oxazepam, which ends a little differently than the others. Now, the intermediate agents have half-lives between 6 and 24 hours, and these include lorazepam, temazepam, and clonazepam. And then the long-acting agents are anything over 24 hours, and this includes diazepam. So this is important because tolerance can happen with our benzodiazepines. And using our short-acting agents, though effective, will need to be used more often. And with tolerance, this can lead to escalating doses quickly, leading to dependence and potentially abuse. So intermediate agents would be preferred. But keep in mind, many are going to be hepatically metabolized to active metabolites, which are eventually renally cleared. So those agents that have longer half-lives have a higher risk of accumulation in the body and adverse drug reactions, especially if there is reduced renal function or hepatic function. The benzos that are considered better options in hepatic impairment are oxazepam, temazepam, and lorazepam. Additionally, this class of agents is going to vary significantly in terms of lipophilicity. And those with high lipophilicity will have high volumes of distribution, like with diazepam and clonazepam. So if drug accumulates and adverse drug reactions result, it's going to take a long time for those agents to leave the body. So a number of pharmacokinetic considerations that will impact agent selection to be aware of. Now let's move on and talk about adverse drug reactions, which we are going to be primarily worried about CNS depression. And this is why combination with alcohol should be avoided, as this can be a fatal combination. One thing to keep in mind is that there is a benzodiazepine antidote that is a GABA receptor antagonist, and it is called flumazenil. So combination with other CNS suppressants, not only alcohol, so things like opioids, will lead to additive effects as well, or if we are giving agents that are going to inhibit metabolism of these benzodiazepines, will increase sedation. So there can be anterograde amnesia as well with these agents. And because of the pharmacokinetic considerations and this CNS depression, there is a significant increase in the risk of falls, and why these agents land on the Beers criteria list and should be avoided in elderly patients, especially those that are going to accumulate. So moving on to our last slide. Now, I hope this video has showcased the pharmacologic considerations that must be weighed when deciding whether or not to use a benzodiazepine for anxiety disorders, and whether or not this is appropriate for specific patients, and if it will be a short-term or long-term option, and which benzodiazepine is going to be the most appropriate of the agents to select from. So this will require significant patient counseling and a deep understanding of their past medical history, so the risks and benefit of the benzodiazepine treatment can be weighed. So I hope this video has provided a nice review of some of the pharmacokinetic and pharmacodynamic topics as well that you should be keeping in mind in each of these videos.